Moving into the relapse setting, I'm very pleased to welcome Jesus and Miguel to introduce the topic of first relapse and what would be treatment options in that setting. So please welcome Jesus.
Miguel.
Right behind me.
Okay, good afternoon. Probably you are a bit tired at this time. You know, until year 2000, only 2 drugs were clearly effective for the treatment of multiple myeloma, melphalan and corticosteroids. But since then, 9 drugs has been approved, and there are multiple potential combinations of these drugs. These are very good news. However, the accessibility to these regimes is not the same in all regions, and probably there are so many potential combinations that to make a right choice, you need a compass. When we talk about personalized medicine, this is the time. You need to consider, when you are in front of a patient at the time of relapse, what are the disease-related factors, the type of relapse, cytogenetic, extramedullary disease, patient-related factors, the efficacy, which is critical, of prior treatment. This is not working. The efficacy and toxicity of prior treatment, as well as the further options. This is critical when you are going to make a decision on the treatment of relapse. The second message that I want just to give you is that the best possible treatment should be used upfront or in first relapse. Otherwise, you are spoiling part of the money. Please concentrate at diagnosis and first relapse. This is not working, please.
Can we get the arrow to work, please? Yes.
Okay.
It was working, but...
I will drive you now through 3 different clinical cases in order to understand the decision at the time of relapse. The first corresponds to a 60-year-old man that was diagnosed as IgD myeloma, stage 3. Is working or not?
It's working now.
No, it's not working. Yeah. He received VTD for 3 cycles, followed by autologous transplant, and 2 years of maintenance with lenalidomide, and the patient relapsed 18 months after discontinuing lenalidomide. Then, in this particular case, I think not. My question is, how would you treat this patient? Would you rescue the treatment with a second autologous transplant? Would you use an allogeneic transplant? You will treat with anti-CD38 antibody combination until progression. Will you offer a clinical trial, or are you unsure? Please vote. It's not working. Please ask. I need that.
It's working. Let's see. Find it.
It's not working. I need this. To press? To press? No. Come here. Okay, these are the answers. Half of you suggested rescue treatment followed by a second autologous transplant, and the other half of you preferred not to go to the transplant and to treat with anti-CD38 combination until progression, which is fine. I think the decision in this patient, according to our personal opinion, is that this patient has relapsed almost 4 years after diagnosis. Then in this particular patient, I will go for the third option. I will treat with a new second autologous transplant. If the patient has had a biochemical relapse, I will repeat probably the initial approach, but if it's aggressive, I will probably offer this patient KRD or KRD plus DARA and the second transplant. By contrast, if I have in front of a patient with an early relapse, that the patient relapsed less than 1 year post-autologous transplant, my goal is to try to overcome drug resistance. And in this particular case, I will go for the best possible treatment, aggressive treatment with non-cross-resistant agents such as KRD PACE or DARA in addition, and then I will, probably this is the only context in which I will consider the allotransplant until we have the CAR T-cell therapy in these patients. Now let me move to the second case, a 70-year-old man that was diagnosed with an IgA, a stage 1 myeloma, and moderate renal insufficiency. He was initially treated with a Bortezomib-based regime, BMP, for 9 cycles, and the patient achieved VGPR that lasted for 2 years. In this particular case, how do we treat at time of first relapse? To retreat with a Bortezomib combination, lenalidomide-dex, Carfilzomib lenalidomide-dex, Ixazomib lenalidomide-dex, Daratumumab lenalidomide-dex, and sure, please vote. It's not working. Okay, most of you have choose Daratumumab lenalidomide dexamethasone, and also 1/4 proposed Carfilzomib lenalidomide dexamethasone, which is very interesting. Also, some people consider retreatment. Let me try to show you what is the data. This patient, after Bortezomib induction, without lenalidomide maintenance, what is approved in most countries is lenalidomide dex until progression. The PFS is 15 months. However, this standard of care, because this has been approved as a standard of care, has been recently challenged by the triplets, combining lenalidomide dex with proteasome inhibitors, KRD, IXA-RD, these are the PFS, or monoclonal antibodies, ILO or daratumumab. But we are in a context that we should not forget that in many countries this is not affordable, and there are economical constraints, and I'm going to discuss this data. First of all, the 2 trials that have compared the 3 drugs based on a proteasome inhibitor plus lenalidomide dex versus lenalidomide dex. As you can see here, in both cases, the CR is improved with the triplet, with the addition of the proteasome inhibitor, 31% and 11% complete responses, and also there is in both trials a prolongation of PFS of 8.7 and 5.9 months. In addition, in this meeting, Keith Stewart is going to show in the KRD versus RD study that there is also not only a prolongation in PFS, but also a significant benefit in overall survival, 8 months improvement in favor of the triplet. Regarding the toxicity of this triplet, if you look to the treatment discontinuations, it's almost the same. It's not higher with the triplet, and the only caveat that you should be aware is that the cardiovascular toxicity that is increased with the addition of Carfilzomib, but we are learning how to manage this. And also I want you to pay attention about peripheral neuropathy. It's 2.6, very low incidence of peripheral neuropathy with this proteasome inhibitor. Regarding the other randomized trial based on a proteasome inhibitor, Ixazomib plus lenalidomide dex, regarding the toxicity, as you can see, the grade 3/4 toxicity is almost the same in the triplet than in the doublet. And in fact, once again here, we have a very low incidence of peripheral neuropathy. But probably the main revolution, the major revolution came with the monoclonal antibodies, completely different mechanism of action, and we have now several monoclonal antibodies that can be used in multiple myeloma. The first one was ilotuzumab against SLAM-F7. It not showed any activity as single agent, only disease stabilization. However, in combination with lenalidomide dex, as compared with lendex alone, it has shown a significant benefit in progression-free survival, is 5 months improvement, and also there is a benefit in the overall survival, indicated that the immunomodulation in this patient takes time, but is clear benefit in the prolonged overall survival. This regime was very well tolerated. The addition of ilotuzumab did not increase the incidence of adverse events. As you can see, infusion reaction occurred mainly in the first infusion and were grade 1 or 2. But probably the most striking data was reported in this study in New England Journal of Medicine, in which lenalidomide dex was compared with daratumumab lenalidomide dex. I would like just to call your attention about the complete response rate that is in the top part of the, oh, here I have the arrow now, is 51% versus 21% with a significant improvement in PFS, that is 17 months in the control arm and has not been reached in the data RD. And this probably, the explanation for this significant benefit is in the minimal residual disease analysis, that as you can see, in a sensitivity to 10 to the minus 6, 13% versus 3%, 10 to the minus 4, 34% versus 10%, achieve an MRD negative status that correlates very well with the survival. Regarding toxicity, once again, we have that the treatment discontinuation is not higher in the DARA arm. We have observed an incidence of infusion-related reaction, but mainly, again, occur in the first cycle and were really manageable. Then, in this patient that was induced with bortezomib, melphalan, prednisone, he not received lenalidomide. Lenalidomide could be an option, but the data indicate that triplets, particularly probably DARA-RD or KRD, are clearly better options. However, not everybody has access to this drug, and there are economical constraints in many countries, and you can consider, since it was very effective and has a treatment-free interval of almost 2 years, retreatment, again, with a proteasome inhibitor such as VTD could be used in this patient. But I would offer in this patient always lenalidomide dex because he has not been exposed yet to an IMiD. And in order to improve the efficacy of lenalidomide dex, why not to add cyclophosphamide? And why I say this? This small study conducted by the Dutch group in patients that were lenalidomide refractory had shown that when they are treated with lenalidomide, cyclophosphamide, and dexamethasone, the overall response rate is impressive, and the PFS is 12 months. And at this meeting, there are going to be presented data on pomalidomide that the addition of cyclophosphamide is able to rescue patients and having very good result. Brian Dury is going to expand on this. But my message is that probably in this relapse setting, the addition of oral cyclophosphamide 50 milligram to Lendex could be a good option if there are economical constraints. Okay, now let me move to the third clinical case. It's a 92-year-old woman that was diagnosed with IgG-kappa, stage 3 myeloma, with a lesion p53 in 20% of the plasma cell. She achieved a VGPR with lenalidomide dex, but on month 24 of continuous treatment, she developed rapid disease progression. And now, please vote about these options. In this patient, when they progress under Lendex, will you use bortezomib dex, bortezomib melphalan prednisone, carfilzomib dexamethasone, carfilzomib pomalidomide dexamethasone, dara bortezomib dex, dara pom dex? Please vote. Okay. The majority proposed dara bortezomib dex, followed by dara pomalidomide dex. Very few people propose other options in this patient. Okay, let me again try to drive you. This patient that has become lenalidomide refractory is in first relapse. Probably the obvious choice will be to offer him bortezomib dexamethasone. And this is what we use and we propose until very recently. But we have data on carfilzomib dex that I'm going to discuss. And on top of this, we have data on triplets based on bortezomib, ILO-VD, DARA-VD, and Panovinostat-VD. But again, don't forget about the economical constraints. This patient has received Lendex progress, and why not to add to the Bortezomib dex an alkylator? I will go through this data. First, we have one head-to-head randomized trial in which Bortezomib dex has been compared with Carfilzomib dex, and the data clearly show a benefit for the second-generation proteasome inhibitor. It's almost double the PFS, and it's also associated, is the second study based on Carfilzomib that show benefit in overall survival in this study, and also double the complete response rate. What about daratumumab Bortezomib dex versus Bortezomib dex? The CASTOR trial has shown also a significant benefit in PFS, median PFS for the triplet 16.7 months versus 7.1 months in the doublet Bortezomib dex, and this is probably associated or reflected the benefit in terms of response rate. The CR rate is 28% versus 10% in the doublet. In this meeting, Sagerlonial is going to present very attractive data on 85 patients receiving, at the time of relapse, daratumumab carfilzomib dexamethasone, 84% overall response rate, and a PFS at 12 months of 74%. We have also opportunity with a different class of drug, the histone deacetylate inhibitors, panovinostat. Panovinostat, in combination with Bortezomib dex, has shown to be superior to Bortezomib dex, 4 months difference in PFS, but this difference is clearly increased if you consider patients that has been previously exposed to both Bortezomib and IMiDs. The difference here goes almost to 8 months in benefit of the triplet. But once again, I don't like to forget countries in which these combinations are not affordable, and for this reason, in this patient that has been exposed to lenalidomide dex, I will not use Bortezomib dex because I know that PFS is relatively short. I would add a third agent, an alkylator, because the PFS increased to 16 months, that is similar to the ones that has been reported with the new drugs. And there are 2 abstracts in this Congress that show, one is a comparison VCD versus KCD. KCD is superior, but with VCD you have 68% response. Another abstract, VCD versus LACD, again 68% response and PFS of 16 months. Please don't forget that with some cheap combinations you can get also good results. What are other factors influencing our decisions? Age, type of relapse, and number of prior lines of therapy. This can be a complicated slide, but I think it's an important slide. What I have done here is I have took all the triplets compared with the doublets, and I have compared the outcome, the hazard ratio, according to age. This study compared less than 65 versus more than 65. Here you have less than 75 versus more than 75. The message is that the data combination in both DARA Lendex and DARA BD clearly indicate that age is not a problem. You can really overcome the negative impact of age because the outcome, the hazard ratio, is the same, and also the same or even better occurs in the Endeavor trial that is KD. By contrast, with the KRD in the very elderly population, the outcome is not so good, probably is quite toxic in this context. It will be better in here to use the KD. What about prior lines of therapy? Again, the DARA studies are associated with very good hazard ratio, but let me explain to you what I want to say. Here you can see that the hazard ratio for DARA-RD is even better with 2 lines of therapy than in patients relapsing just after 1 line of therapy. By contrast, in the CASTOR, the patients that benefit more are the ones that are relapsed after 1 line of therapy. And again here, you have that in the ASPIRE, the number of lines of therapy does not impact, by contrast, impact a bit in the Endeavor trial. Then I would suggest that it's better to use, if you are going to use DARA-VD in first line, that instead of second line, the same apply for KD. By contrast, the triplet KRD and DARA-RD becomes very active also in second or subsequent lines of therapy. And what about cytogenetic abnormalities? Again, here we have the standard risk and below the high risk. If you look in most of the studies, you can see that the hazard ratio is clearly in favor of the triplets, but we want to concentrate on the combination that is able to overcome the adverse prognosis. To overcome the adverse prognosis means that the high-risk patients do as well as the standard risk. And here we have only the IRD that do even better than the standard risk. Here you have that in the other, usually the standard risk do not as well, the high risk do not as well, the standard risk patients. And I think now I would like you to focus on the two last slides because are the conclusion. And the conclusion are always very important in presentation. And I'm sure that you share with this dog the message, but particularly with my grandson. But he has a very clear ideas about this presentation. Thank you very much for your attention.
I'll go ahead, yes.
You go?
Yes. So thank you so much, Jesus, for this excellent presentation, and also emphasizing and bringing into play the access to these relapse regimens and the economic factors, which really does impact the way that you might answer some of these questions. And so, first of all, I'll go ahead and show you what the panel did for these different questions. And so this first case with translocation 414, VTD, relapsing after 18 months following LEN maintenance. And what did we say? Well, I think that the DARA data are obviously very strong and have very much influenced, or I would in some cases dominated our decision process, although Philippe does say that it would be okay to consider the rescue stem cell as well as Vincent. Yeah, so would someone like to comment on the pros and cons of the repeat stem cell versus the DARA? Would you like to comment on that?
Well, I think that there was a consensus paper written on how to use salvage stem cell transplantation, proposing to do this salvage transplantation when the first duration of the response was something like 12 to 11 months. I think that's not enough.
Okay.
In my department, we are trying to use at least a 3-year duration of response.
Okay.
If you have a long response, then you can re-challenge with the stem cell transplantation.
Yeah.
Yeah.
Although the answer that I chose was the double possibility. Again, if I think in an economical constraint, this patient has relapsed almost 4 years after diagnosis, I think the the salvage transplant after reinduction will be probably the best option for them because we'll associate it with longer PFS.
Vincent, you want to comment? Yeah.
Yes, I agree with what Jesus and Philippe just said. I mean, the 3 years is what we use as well, as long as the patient's on maintenance, because you expect at least 4 years, and if they get 3 years at least, then a repeat transplant is very reasonable. I want to make one more point. The transplant is the one that is really limited by age and performance status much more than daratumumab is. You can always do the daratumumab once the second transplant doesn't work, but you cannot do it the other way around. In many patients, they might become too old for the transplant.
Right.
So if you think the transplant's given them a very long PFS the first time,
Yes.
maybe try that first. The DARA will always be around.
Right. Okay. So then the next point, an older patient with the VMP, the Spanish favorite, for 9 cycles that lasted for 2 years. And when this patient relapsed, we all picked Dara Landex for this. And so I think that those data are obviously quite strong. For the next case, an older patient with a P53, Landex, and then rapid disease progression. Again, since the patient had been on an IMiD, we switched to the Dara Velcade Dex, and Jesus showed rather clearly the impact of these different regimens related to the cytogenetic risk. Okay. Yes, so these different points. I'm just going to skip over these. And before we go back to the audience, any other broader comments? I think that the point that you made, Jesus, about what would be reasonable options when Dara might not be available or some of these drugs are not available. Obviously, the results are not quite as good, but with response rates of like 68%, for example, versus maybe a little bit higher if you happen to have access. You want to comment on that a little bit?
I was really surprised with the data of adding cyclophosphamide to lenalidomide dexamethasone. The Dutch study, in fact, when I reviewed this paper, I was really in doubt of the so positive results. But now we have with pomalidomide cyclophosphamide dex very solid information, and the same for relapse. If you are living in a country you have not options economic, and you have an economical constraint, the patient has received Lendex, the patient relapse, Bortezomib dex is probably insufficient. But if you add Cybordi,
right,
cyclophosphamide oral, 50 milligrams per day, you can increase double the PFS. Then I think this is an option in those countries.
Right. Okay, so questions or comments from the audience? Yeah, this gentleman right here, if there's a microphone, please.
Yeah, I'm over here to your right, in the back.
Oh, okay.
Yeah. So,
okay.
Yeah, I'm Tony Blau. I'm a hematologist. I have myeloma. I have a startup called All4Cure. And the thing that I wonder about is when you become MRD negative, how many myeloma, which I've fortunately achieved,
in the relapse setting, are you talking about?
After an auto transplant, allo transplant, 1 year after the allo transplant, for the first time MRD negative, 6 months later, MRD negative again.
All right.
I'm wondering how many myeloma cells could still be lurking around in my body. And if I do a back of the envelope calculation, and I think people estimate that our bodies have 37 trillion cells, and if you put 1 to 2 trillion in your bone marrow, that still calculates, if you have a 1 out of 10 to the 6th sensitivity, I could still be hiding easily 1 million myeloma cells that we would never detect. And so I guess, and I don't have a great answer for that other than time. I think over time we'll see whether I'm cured or whether I have 1 million myeloma cells left. But I wonder what you guys think.
Sure, so this is obviously a very, very central point. And I know that this is something that Bruno has been quite worried about recently, even with the 10 to the minus 6 sensitivity, where you can see these curves with a little bit of what seems like maybe linear relapse, which is still occurring at that 10 to the minus 6 level. So do you want to comment on that, Bruno?
Well, it's a very, very important point, and it's not really a question, it's a point, a message, and a very important one. I think that really echoing what was said, if you start with 10 to the 12 or 10 to the 13 in tumor mass, really defining an MRD negative result even with a limited detection of 10 to the minus 6, which is what the next generation techniques offer, you can still have several tumor cells. And I would say that given the allogeneic stem cell transplantation, I would say that it's particularly important to combine a technique that measures MRD in the bone marrow flow or sequencing with, again, an imaging technique. We have seen in the past, and we have reported this a few years ago, that the only setting in which we struggle to see a clinical benefit after an MRD negative result by flow cytometry was in patients in CR after an allogeneic stem cell transplantation as a salvage therapy. So definitely there, I would recommend using both cellular and an imaging method. Realizing that an MRD negative result is a surrogate for clinical benefit, it should not be considered as a surrogate of cure. And also the importance of sustaining that MRD negative result over time. I think that a single snapshot, a single picture is not enough if you want to predict the future at the long term.
All right, so unfortunately we have to go ahead. So let's just ask these questions again and to see if any of the selections have changed. So this first case, the 414, and then after land maintenance, sorry, get this. How would you treat this patient? And we talked about rescue versus a CD38 approach. Let's see what people think now. If you could vote on this one. Okay, so it seems that our discussion did push the second transplant a little bit to the right, actually, what did it do? It decreased the use of clinical trials, is what it did, yes, but certainly increased the selection on second transplant. So interesting there. So let's go to the next point, VMP, and then follow-up options. Okay, how would you treat this patient? Retreat, or actually a variety of options. If you could go ahead and vote on this one again. Dara wins out on this one. Really, yes. Well, the data are really rather strong. Carfilzomib also dropped down, and Activism, yes. Okay, interesting there. Let's keep moving forward. So this is patient. How would you treat? Let me go back. I'm so sorry. Yeah, there we go. So this is a patient who had a P53. VGPR, and then 24 months, and then developed rapid progression. So lenalidomide, and then in the setting of P53. And what would you pick here now? And I'm not sure what that number 5 was. That's Dara. Oh yes, it's okay. So Dara is winning out very, very strongly. Yes.